He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
All right.
Welcome back, folks. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. Our guest today is Johnathan Edwards, who shares the distinction of having the same name as a famous 18th century evangelist, which that's probably not the first time you've heard that. And I don't mean to send the listeners down a rabbit hole, because don't bother. Phil, why don't you take it from here, man?
Sure thing. Happy to have, as anyone watching on YouTube will pick up, we got another guy in scrubs here. Not a surgeon, but on the other side of the drape, as we call it. We got an anesthesiologist on today. Good friend of mine who I'm excited to have this conversation with, Dr. Johnathan Edwards. And I think, like many of the guests we've had on, Johnathan's got some unique perspectives on health, on pain, which is an area that he deals with a lot as an anesthesiologist. And there are going to be a few very interesting topics for us to jump into. So before we get to that, John, why don't you give a little bit of your background to our audience?
Yeah. So thanks. Yeah, I'm a 25-year veteran anesthesiologist. I trained at USF, did my pre-med at UC Davis. I've also trained in France. I did a year of neurology there. I'm an fluent French speaker, and I still live in France part-time. Like yourself, I've written my share of books. I've got, my latest books is Stopping Pain, and that's on a French technique called Percutaneous Hydrotomy, which we'll get into. And then the other book before that is another dear subject of mine, treating suicide, depression with ketamine, which is, as you know, a drug anesthesiologists use all the time. And that's, kind of my segue into that. But yeah, that's a little bit about me, and I'm just kind of a polymath, but I love it all.
You've already used three words that us average people don't know, but we'll come back to that.
Yep.
Yeah, we'll definitely get into some of those things that you talked about. I guess, maybe a little kind of primer here for our conversation will be, we met at a metabolic health conference, and honestly, I knew your name prior to that and knew of you prior to that because of your association with Dave Feldman, who we've had
that's great.
So talk a little bit about that kind of background, and then maybe we can get into some of the interesting areas that you've been exploring.
Yeah, no, I've been going to the Metabolic Health Conference since its inception in San Diego way back, I think 2018, if I'm not mistaken, was the first one. I went to that one, then the Tampa one, and then I didn't get to go to the other ones because of the COVID and all that kind of thing. So I've known Dom since way back then with Dave Feldman, and he was a speaker there. Dave and I circuitously were introduced through a mutual friend who was also a speaker at that conference named Peter Defty. He's optimized fat metabolism guru guy. And anyway, he introduced Dave and I he knew we would be a good fit. And then Dave started getting into the testing, and he was starting to show all his cholesterol data, and that he could, drop his cholesterol from, 300 to 100 in 7 days. And he was showing me the graphs, and he was saying, but man, the testing is just so expensive. And we were both in Vegas, and I said, just use my account. I have great cash prices. And so that's where we started, and then I started helping him with that and made it possible for him to do the testing. And so I've been with Dave as a kind of a founding partner in the whole ownyourlabs.com business since its inception. And I've supported Dave and everybody, Dave, Nick Norwitz, and everybody involved. And that's been one of my great achievements with that.
That's cool to make that connection finally.
Yep. So, and that's how John and I got introduced.
Dave Diamond.
it may not seem intuitive to people in our audience. They're here thinking, okay, you're an anesthesiologist, put people to sleep in the operating room and manage them in the
Right.
operating room. What is this other stuff? Why would you be thinking about metabolic health? How'd you get into some of these other areas that aren't on people's radars when they think about anesthesiologists and what they do?
Yeah, no, my backstory, and that's pretty interesting. So I used to race professional motocross before medical school. So I've been a professional athlete, and then I actually got into bike racing in my 30s, and actually went very far in that. Went up to become a Cat 1 cyclist, and even raced against Floyd Landis and some of those guys, in local pro races. I had a bad fall in cycling. Fell at about 40 miles an hour coming down a hill with a good friend of mine, sustained a bad concussion, and I got what's called a sixth cranial nerve palsy. So I had a definitive concussion plus brain trauma. I had known about the ketogenic diet and using that for brain injury and brain trauma because in my rehabilitation residency, which is physical medicine and rehab in Utah, we were using ketones for brain trauma that we would often see. A lot of the skiers get brain trauma there. I was at the University of Utah for 1 year. So I knew from that, and I got real aggressive, and I went on a strict ketogenic diet. And I was measuring ketones, my glucose. I was already in its very good shape, but I was seeing double vision. I had to stop practice for a good bit, and I was determined to do something about it. And so that was my foray into, say, the ketogenic diet or this lifestyle. And I have to say, once I started, I immediately saw the benefits. I would have a glucose meter on, and my glucose readings would be 50s, like all day long. And I'd be no brain fog at all. But in any case, my symptoms were getting better. My double vision finally corrected itself after a couple months, and I just stuck with it. And that's that. And I've been a proponent of the ketogenic diet and that lifestyle ever since. And I could have never guessed how it would have played out up to my life until now, which we'll get into. But that's how I got into it all.
I just want to put the pieces together here. You sustained a physical injury.
Yes.
Explain what that injury was again.
So I hit my head at about 40 miles an hour on a bicycle with a helmet, destroyed the helmet, of course. I woke up in the back of a truck, and then, I got a head MRI, all the CT, and then it revealed an injury to my cranial nerve in my head, which is one of your 6 nerves that control your eyes. And because that
and that's where
was
the
injured,
double vision came from.
That caused double vision. And I thought, my career could have been done right there,
And so going to a ketogenic diet
for brain injury. Yeah. There's lots of literature and there's lots of peer-reviewed research showing ketogenic diets helping brain injury and brain inflammation through ketones. And a lot of this work has been shown by Steve Cunane, for example, at the Metabolic Health Conference and many others, that ketones can indeed help brain trauma and brain inflammation. And that's where I've been a huge proponent of it ever since. And, so a lot of people I work with, I steer them that way. So.
Wow. Okay, Phil, I get it now. I understand why he's here. Okay, yeah. I didn't mean to interrupt, but I was just trying to connect the dots there.
Yeah. And that's just really a brief foray into some of the things that Johnathan has done that I was looking forward to discussion. That kind of leads into one of your interests, which is, working with professional athletes and dealing with, I guess you could say, injuries and the inflammation and pain that goes along with oftentimes these high-level athletic pursuits has led you to pursue some other, treatment modalities. And you mentioned the book that you recently wrote, Stopping Pain and Percutaneous Hydrotomy. And
Okay, you guys are gonna have to explain
yeah,
that one.
we're going to
Yeah.
dig into it because I fully admit I had never heard of it and had no idea what it was prior to talking with Johnathan. So let's talk about what that is, how you got interested in it, kind of the history of it, and and then we'll talk about some of its potential benefits.
Yeah, so this I'll just give you some background. It's called percutaneous hydrotomy. Percutaneous infers that you're going through the skin into the subcutaneous portion of the tissues. Hydrotomy is simply using water. But to back up, yes, I work with many professional athletes, and it's one of the reasons I wanted to learn this technique for many reasons. But I work with UFC fighters like TJ Dillashaw, Francis Ngannou, Bo Nickel I've worked with, David Taylor, he's an Olympian. These are all wrestlers and in the UFC world. And motocross, there's Zach Osborne, I've worked with some tennis guys. I've worked with Roman Bardet and, in cycling, I've been a team doctor for those guys. So anyway, yeah, I have a big professional clientele, if you will, that, I need to be pretty innovative and help them in ways. And what I do from my rehabilitation and anesthesia background is I help them guide their rehabilitation, their nutrition, their recovery, and strategies to optimize themselves, within their guidelines and rules. So I guess that's what you could say I bring to the table versus, say, somebody else who hasn't been a professional athlete. Like when it comes to nutrition, for example, I'll put myself up against any dietitian, anybody. I've been into it since I was one of those guys in medical school who delved into the nutrition really hard on my own, because I knew medical school wasn't going to teach it to me, and I took it upon myself. And I'm proud to say I'm one of those guys like yourself, obviously, who's who can say as a medical doctor, I know the nutrition, I know the science, I know the metabolites, I know the Krebs cycle, I know so anyway, so in my training in France, I came across many different modalities, as you can imagine. And one of them was mesotherapy. So mesotherapy is the art of using subcutaneous injections locally over the area of pain. And it was originally designed for musculoskeletal pain. So in France is where I learned percutaneous hydrotomy, which is basically just a form of mesotherapy, which involves tumescent anesthesia. It involves
What kind of anesthesia?
Tumescent. So tumescent means to swell up the subcutaneous tissues. It's used often in plastic surgery.
Okay.
So, like when Dr. Ovadia does, lidocaine under the skin, I mean, you're making a tumescent basically, right? It's just that peau d'orange. It's, but it's much more than that. But to give you an idea, that's what it is. So it involves tumescent anesthesia, oligotherapy, hydrotomy. And then imagine, say you have knee pain or shoulder pain. Now we're going to place subcutaneously a volume of fluids, a volume of local anesthetics, a volume of anti-inflammatories, some other medications, plus some vitamins, plus minerals, plus amino acids. It depends on what you're trying to treat, whether it's knee pain or shoulder pain or back pain or migraines. It's all different. Long story short, a couple of years ago, or well, actually 2020, I went during COVID and I actually trained with Dr. Gez, who kind of created this technique in France. And he'd done over 500,000 of these procedures. And I was just amazed that it never got to English speaking countries or even America. And the reason is because it's only taught in French. And I'm a French, and since I speak French and I'm fluent in French and, French medical, all that, I went over there, learned it in French. So that's when I wrote this book about percutaneous hydrotomy, because the only other book available on it was in French. So I agreed with Dr. Gez and I wrote it up. It took me about a year, and it's one of those things that, I don't think a pharmaceutical company is ever going to come and, monetize it, just because it's just such a basic injection procedure. It's a, subcutaneous injections have been done for decades,
Right.
back in the 1800s. It's nothing new, and almost all drugs are safe to inject, but it's something that's not taught. So anyway, but it's a simple technique to treat musculoskeletal pain, especially osteoarthritis, and it goes well with the other. You can consider it one of the regenerative, therapies like PRP, stem cells, prolotherapy, and then now you got this thing even called percutaneous hydrotomy, and it's using water to separate tissues. I mean, it's an out there term, but anyway, you get, this is nothing way out there or out of the realm of what we already do in medicine or surgery or pain medicine already. And if in the book, there's like dozens and dozens of patient testimonials, and Phil has seen some of these, and that's how he knows about it. And it's, and I'm just teaching one person at a time, really, and then I think it'll take off on its own. It'll grow organically, I think. And that's my goal with it, right? Really, it's not like it's a great little technique, and it can help a lot of people. And it's like I said, yeah.
So this is actually regenerative, like somebody.
Yeah, I mean, there's actually studies from UCLA in 2016 with Dr. Roy Altman, who's passed away now, but he showed that saline is not a placebo. Almost all studies were done against saline, and he showed in a meta-analysis, and it's all in the book, all the references are there, that saline is not indeed a placebo. It actually helps the pain. It actually helps the injury. In every study he went over, there was an effect of just injecting saline, and so what, you can theorize what.
So yeah, I'm guessing Big Pharma is not interested in this particular treatment. Okay.
No, but things like Humira and monoclonal antibodies are also administered in this fashion with large tumescent subcutaneous injections. So like I said, there are other avenues of medicine using this already. And just think of it, it makes sense. It's a slow release deposition of products to the injury. That's it. I mean, it's not harder than that, and I think its simplicity is its power, really.
Well, I guess I'm more interested in the regenerative part. I can understand because when I think about, okay, an anesthesiologist, he's going to help me sleep through the surgery, which is great. But what would be better would be if this torn up knee that I've got was actually healing and get, whatever injury I did to it, if there was a way to get it back to healthy. That's what I'm hearing.
Yeah. Yep. And
am I hearing this right?
Yeah. So if we decrease the inflammation and we give your cells that are pissed off, the ability to take in nutrients, and then, so there's many factors. So think about this. We're going to block your pain cycle. Your cells are making, TNF alpha, all these mediators, the bradykinins, all these things that tell your brain hurt. The local anesthetics break that pain cycle. That's well known. Every pain doctor does that, So you do that. Now, what else are you doing? You're giving the cells water to exchange, because you do create, water movement when you create, to get technical, a hypertonic environment outside of the cell, which promotes water movement in and out of the cell. So you're doing that. You're also letting, those cells in some capacity take up the minerals, take up the amino acids. So in that sense, those cells are sick for a reason. They have to be sick, right? They're hurting. Right. They're non-functional. Those are your chondrocytes. Those are, or whatever, the cells making up and your tendons and ligaments and things, and your meniscus, for example. Is it a miracle? Is it like Miracle Grow? No. Is it something that can help towards the regeneration? Yes. Are there like microscopic studies? No. But we don't even have those studies for stem cells nor PRP. They all say it happens, But I'm sorry, those studies are not, I mean, nobody's really shown 100% those studies like on electron microscopy. Here's your cells regenerating on stem cells or exosomes or PRP.
Right.
So, which brings it into the picture. When you combine like something like percutaneous hydrotomy along with stem cells or PRP, which I do, and I mean, I can tell a story. I had a motocross racer come in with a rotator cuff injury, and I used a combination of the percutaneous hydrotomy and PRP on him each time. So on the surface, I would do the percutaneous hydrotomy, and it looks like his shoulder just got out of arthroscopic surgery in a sense, not as big, and then in the joint or in the areas where he hurt his tendons, and I would do it with ultrasound, I would inject the PRP there. And I mean, this kid went from having his arm pinned to his side because of the rotator cuff to racing in 4 weeks.
Holy smokes.
So,
My
I mean,
brother-in-law just ended up with a torn rotator cuff, and he's been out of business for weeks.
Yeah, for frozen shoulders, it can actually do things. And for back pain, I mean, I've seen it do things. Now, if you have bone-on-bone arthritis, it's not going to do much for you, but nothing is going to do much for you, So it's knowing its risks, benefits, and alternatives, and being realistic with the outcomes, I think, is, the power, of these kind of techniques. And that's what I don't try to sell this as a miracle. I try to sell it. I don't try to sell it. I just state that it's a technique which can be used in between some injury and the endpoint of surgery. That's all.
Yeah. Yeah. And as you alluded to, this has actually been used quite widely in France for over 20 years. Dr. Guez has, developed the technique and, has large clinics and has trained many other practitioners in France. But there was this barrier that you had to know French to go learn from him. It was kind of fortuitous in some ways. Now, we should mention there has been some controversy around this technique in France. And so
I can go into that, and I've written a lot about it.
Talk about that a little bit, because if people look this up, they'll certainly come across that.
Yep. And then, so that has to do, this all came post-COVID. As we all know, there was a big change in the landscape of medicine in Europe. And not so much the States too, but medicine started following this narrative that, it had to be studied or it wasn't any good. No longer was it good enough to have, observations or doctor experience or those kinds of things. But basically the French Board of Medicine stated it was their what they called their fight against what they call fake medicine. And they included chiropractor, osteopath, mesotherapy, naturopathy, a lot of things, hypnosis, fasting, and then they also added percutaneous hydrotomy in there. And it's not because there were patient complaints. It's not because there were patient injuries. It was, we don't know why this came up. Who's behind telling the Board of Medicine, basically it's one board because it's a country of France. So in a sense, you could think of it like a Board of Medicine, but it's really the federal French Board of Medicine. And you can go to it. They listed 25 different alternative specialties and basically said, nope, we're not supporting these anymore. And, and it's kind of ironic because France has always been the bastion for alternative medicine. The French hate taking medicines. They will take plants and herbs before taking any kind of medicine if they can help it. And over there, the pharmacist can help you with this. So that's what's going on over there. And it's true. I mean, the French Board of Medicine has taken things like mesotherapy and others and say, there's no studies for this and there's a risk of infection. And based on that, I kid you not, based on just that, not injuries, not patient complaints, not anything. And it's been, and they've actually threatened doctors' licenses because of it. And it's getting pretty bad. I hope it changes. And so I think in the US, we're we're still progressive enough that, hey, if the patient wants to pay cash and, you're not going to submit this kind of stuff to Medicare, I don't think there's going to be a problem with it. But it's important to bring it up because if we, I mean, I've gone to a chiropractor all my life, and I don't go all the time, but when I need a chiropractor, I like going to a chiropractor. They do what they do. They release your joints, and I've always benefited from it. But France is actually suppressing those kind of practices. And then to tie it in with Article 4. So Article 4 is, as you may have heard, it's basically their fight against medical cults, in a sense. It's a dérive sectaire. And they want to stop like these fasting cults, if you will, so they, and they've had some suicides and deaths because of it. Not on a grand scale, it's sad, but they basically said that if a healthcare practitioner tells a patient advice off of the mainstream narrative of medicine, that they can be fined $45,000 and up to 3 years in prison.
Yep.
So you don't have to guess where, the spirit of that law, and I watched the whole thing in French for 3.5 hours. And the spirit of Article 4 is, as it says, it's to stop sectarian cults, from this, what anybody would call an unreasonable charlatan practice of healthcare, but that law is equally written. It can be used for anything. And that's the problem with it. And that's why it was so controversial, and it barely passed, apparently. And it's a big topic I've been writing on my Substack. I love France. It's my second home, my second culture. But yeah, I don't know. A lot of people are against this Article 4 because, it comes down to the mandate. It comes down to the mandates that you accept today are going to be there 5 to 10 years from now, and you don't know what's going to happen in the future.
I would love to comment, but it's more of the same. We know what's going on. Let's not pretend we don't know what's going on.
Right.
This is nothing to do with making sure people get well and stay well.
Nope.
It doesn't have anything to do with that.
And it's a scary precedent that's being set. And quite frankly, it's not too far from us. California,
they
tried to pass a very similar law.
2098, I think. Yeah.
Yeah. And actually, I believe it did get passed, but they had to repeal it. But it was basically going to give that power to the state to decide what they wanted to label as medical misinformation, and then, have a way to persecute or prosecute, I guess, depending on how you want to look at it.
I think France, right. Yeah. So anyway, we can kind of just leave that at there, but that's what that's about. It is happening in other countries, but France is in the spotlight right now for that. And it's one of my things I'm trying to raise awareness about, but it all goes back to, what is the controversy behind percutaneous hydrotomy in France? And that's it, and I can tell you, I've talked with Dr. Gez at length, and I really have gotten to the deep questions. There's not a single injury or a single complaint. I can tell you that. Not, nobody's sent complaints to the board, and it just hasn't happened. So it is what it is. And, and all we can do, I think, is raise awareness and practice as we do and do what we do.
I think we can do more. I think we can mock anyone who says this is just good science.
Yeah, that's for sure.
How's it pronounced? Iatrogenic, physician-induced injuries and deaths. There are hundreds of thousands of those every year. Following the guidelines, doing what allegedly the guidelines tell us to do.
Yeah.
It's high time we started mocking this. It's absolute folly.
Yeah, and people, a lot of people have, I mean, it's
I'm
definitely
not a
starting.
physician. I don't have a license to lose. So
Right.
I understand where you guys are, and I don't fault you in the slightest for being more careful than I'm being. And I realize I'm not being careful. But
No, you're being,
I'm
it's
I'm
got to be
just
out there.
I'm
Yeah.
so done with pretending that these people are actually that the driving force is altruistic. It's not.
No, and it needs to go back to that, because if you're not taking care of patients, you're not aiming for the highest good to treat that human being, and we're getting away from that. And you're right. It's something that is what it's about at the end of the day.
And
Well,
we've touched on it before on this program, on the podcast with some of the guests that, one of the biggest, I would say, problems with the healthcare system is that, the physicians are not in control any longer. Really, the physicians have largely, given up and or had taken away their autonomy to decide what's in the best interest of their patients. And instead we have, other forces like politicians trying to dictate medical care that gets delivered. And as Jack said, clearly that is not based on what's best for the patient. And while that gets put forth as the excuse for it, we know that there are other interests here that are interfering with doctors, with practitioners' ability to deliver treatments to patients that can help. And percutaneous hydrotomy is really ends up being a great example of that, because you look at it, it makes intuitive sense. You have an area that's injured and inflamed, and you're going to bathe it in nutrients and anti-inflammatories and anesthetic agents that can help numb the pain to aid with healing. And you would say, how can that be harmful or dangerous? At worst, maybe it's a sham, maybe it doesn't work, but it's really not going to injure anyone. And yet we see a technique like that being attacked. It really gives you insight into what's going on in the system.
Yep. Yeah, that's well said. Oh.
so let's get positive now. What's the, you know, the, we've got an audience that's split between healthcare practitioners who are just trying to see what everybody else is doing and enjoying having and enjoy the education that happens, and everyday folks who are, want to avoid sickness or want to recover from something.
Yeah.
So what's the message that you've got? What's the positive, here's something you can do message for that second group? If you're stuck with this kind of problem, here's a possible solution.
Yeah. I mean, it depends what, from a dietary standpoint. I mean, I'm totally in line with, what you guys are doing on the podcast and others, with Dave. And, I just been eating a whole food diet. And I mean, I have an interesting story. I eat pretty much carnivore-ish, but I order all my stuff from like Joel Salatin. I've been to his farm. I've been to White Oak, White Oak Pastures, U.S. Wellness Meats, all that, So I eat a lot. That's mostly what I do. I just eat, just fish, poultry, steak with some vegetables, some butter. That's what I've been doing for almost 15, 20 years. And I'm one of those lean mass hyper responders. So my story is a good one to tell, and it will lend to this to this recommendation. So I've been one of those guys, and I am in that group. I was not in the study, but I am in that group. I've had LDLs. My LDLs are in the 180s, 220s. I think the highest I saw was 253 or something like that, or and it's always been up like that. And then I've done all my NMR, lipoprotein testing, my ApoBs, all that are pretty much elevated. And so
Interpret that, please.
So these are all your lipid tests, that we do at ownyourlabs.com, say for cardiac risk stratification, or to, kind of like it's a first look. There's many layers to looking at cardiac risk. As Dr. Ovadia will tell you, you got, and so one of the easy ones is lab testing, right? Your insulin levels and your fasting glucose. and your CRP will kind of tell you your inflammation, and then you have your lipids, which are cholesterol, your LDL, your HDL, which are, various types of cholesterol. And I won't go into which ones are good or bad because frankly, I don't think we really know. Then you have ApoB, which is a protein on the LDL. It makes it ApoB. Then you have lipoprotein little a, which is, it's a protein on the LDL. I may be a little off on that, but that makes it lipoprotein A. And then you get all these levels on a lab test. And statistically, we take those and say, X, you have a risk, or your risk is low, or your risk is very high. And that's how doctors have practiced, for years. And basically they just take your total cholesterol and, and I've been offered statins forever and I'll never take them. But anyway, so I went further. I did a coronary artery calcium scan. It was 0, of course. But then, and I've been an athlete all my life, as I've stated. It was COVID the first time or second time. I only had 2 of them, but I had it for a good amount. And then I had I had bad chest pain. And this is a story I was telling Dr. Ovadia. I had crushing chest pain. I thought, I'm having a heart attack. There's no, I was out running and I just like this chest, I knew what it was. I stopped, chest pain went away. And I was like, maybe it's just indigestion. Nope. Started again. Elephant chest pain. Stopped, went away. And I was like, oh boy. And then stupidly, I actually went for it again just to make sure. And yep, that's the knucklehead in me, of course, the physician. Yeah, maybe. So sure enough, it came back. I walked home with my head between my legs, my tail between my legs. And then so I got an EKG right away. I got tests, and then all that was kind of normal. It didn't show any bad ST elevation or anything. I was like, what the heck is this? So then I got a CAC scan, and then I did a stress test, and nothing really showed up. And then, I got with my cardiologist, who's a very good friend and colleague. And he just said, Johnathan, you probably had myocarditis, that's all we can think of,
Which means just a swollen heart.
You could have a swelling of the lining of the heart or in the muscle of the heart. And and it's a gray area between which of the two you have, or if you have both, or to the extent you had it. I didn't have a severe case. I had a case that caused chest pain though. And then one doctor brought up like it could have been Prince-Mental's angina, but it wasn't that, I didn't have any EKG findings, nothing to suggest that. Anyways, it's just a diagnosis of, we don't know. And was it myocarditis from having COVID itself? Probably was, because the last vaccines I ever got were over a year and months before that. I don't know if that could have contributed to it. Possibly. That's a rabbit hole I'm not sure we want to get into, but you got to leave. The possibility is open, but I just think I had a pretty bad bronchitis during that episode. So anyway, I really do a big deep dive with my cardiologist, and he goes, Johnathan, you're fine. Just rest 6 weeks, take colchicine, and treat it like a regular myocarditis. And that's what I did. But then I called him back and I said, no, I want a heart cath. And I said, I have a 12-year-old daughter. I'm an athlete. I'm not going to kid myself that I might have heart scarring, or, I've been an endurance athlete my whole life. And I know scarring of the heart can occur, and you can have other cardiac abnormalities from just, from an overdosage of exercise, which I've done. I'm not going to sit here and, aspire to, that much exercise is good for your heart. No, it's not. And we have another story I did with that. But anyway, so I got the heart cath, and of course, as a typical anesthesiologist, I go in awake for it. No sedation whatsoever. He puts some little local anesthesia. He fishes the catheter into my heart. I feel it tickling in there. And I'm looking at the screen, and he goes, Johnathan, you're going to have something. Your LDLs are like 250. And I think you're really going to have something. We'll fix it for you. Don't worry.
So the stent was just exploratory?
No, the catheterization.
Catheter, I mean.
Yeah, was exploratory.
Okay,
And
they're just looking for stuff. All right.
correct. So
Gotcha.
he injected the dye, and I'm looking at it with him, and it's like completely clean. And he looks at me, he goes, I don't believe, he just shook his head and said, I don't believe this. I have to do this a second time. And I say, go ahead. So he does it a second time. And I mean, I kid you not, my cardiologist colleague looked at my scans over and over again for over 5 minutes. And he basically came back and looked at me. He said, Johnathan, not only do you not have atherosclerosis, but you don't even have age-appropriate atherosclerosis.
Despite the fact that you've had this high cholesterol for your
15 plus
life.
years.
Yeah, yep. Which was what was so baffling to your cardiologist.
He really thought he was going to be putting a stent in me that day. He really did. And it was, it's just and so anyway, to circle back, so I fit in that lean mass hyper responder. I'm a lean mass build. I have high LDLs, and I eat, basically a high fat diet. And so it's, and then as you know, the Matt Budorf study with Dave Feldman and Nick Norwitz and all that just showed the lean mass hyperresponder after 5 years. And I wrote that up on my Substack, and, and a lot of those people are on ownyourlabs.com. But yeah, they showed after 5 years, and 100 of those people matched to controls also didn't have an increase in atherosclerosis despite eating a high fat diet outside of the guidelines. So after 5 years, and that's just a small subset. I mean, and there's many more people like that. And it's interesting to see how this has kind of flipped the whole lipid hypothesis on its head, at least in this population. It can't be, we got to be careful here because, you got somebody, who's kind of obese and has an inflammatory syndrome. They're pre-diabetic, their insulin's high, their fasting glucose is high, they have other inflammatory mediators. That's probably, that's a different animal. But in those people who are what we'll call, what Dave Feldman coined, lean mass hyperresponders, apparently practicing a high fat ketogenic lifestyle is not detrimental to the coronary arteries.
That's just awesome all by itself.
Yeah,
I remember
when we're eagerly awaiting the further results from that study to look at the follow-up on these patients. Before we kind of run out of time, I did want to talk about one of the other interesting areas that you explored, and your other book is talking about ketamine.
Yes.
People may be familiar with ketamine. It's a drug that is used as part of anesthesia protocols. It's, I guess, gotten some notoriety as, it's also become a drug of abuse in some circles. Again, or has a history as that.
Right.
But one of your books is looking at the very interesting and the therapeutic potentials of ketamine when it comes to depression. And I think it would be great to talk about that some as well.
So I wrote the Revolutionary Ketamine, and I wrote it with Gavin de Becker. So Gavin de Becker, he's a well-known security specialist. He's been on Joe Rogan, Tucker Carlson. He's been in movies. He provides the Secret Service for Robert F. Kennedy Jr., if you will. He also provides security for Jeff Bezos. He's, I think, Elon Musk and those genre of people, if you will. So I work for him and do some consulting. And anyway, he's a good friend, and we got to talking about ketamine. And he sponsors ketamines for his women's battered shelter. And what ketamine can do is stop suicide. Ketamine can stop suicide in its tracks, and it's the first drug we have in over 50 years, and one of the first drugs ever to really be effective against suicide and depression. Before ketamine and those class of medications, we've only had serotonin uptake SSRIs, serotonin specific uptake inhibitors, reuptake inhibitors. And there's been many of those, tricyclic antidepressants, those kinds of things. But we've known ketamine can work since the 1970s, but it really wasn't elucidated until the 2000s in Yale. And Dr. John Crystal and Berman and some other colleagues, they elucidated in a landmark study called The Will to Live or the Will to Die. And they showed conclusively and repeatably that ketamine stopped suicidal ideations. And then I went on to write the book about that. And then I also did a speak event talk, which is a TED talk, basically. They're a breakoff of TED Talks. And I did that talk in New York last November. And that's on YouTube. So that's, if you ever want to, that's a really good 10-minute view and gives you an idea. And the other reason is my grandfather committed suicide when I was 7. And I've always been interested in why suicide, how suicide. And I mean, as a young child seeing that, it sticks with you. Going into medical school, I'm sure, Phil can attest that, we all were in psych rotations and we also saw people just kill themselves for what we think is nothing. But for them, it's, walking in the fog, disoriented in lead boots. And so to be able to provide this kind of treatment, especially to, young adolescents where, we're seeing a lot of increase in suicidality in 15 to 24-year-olds. In fact, it's the 3rd leading cause of death right now in that age group. Wow. And you got to ask yourself, why? And I recommend Johnathan Haidt's book, An Anxious Generation, if you want to know more about that. But anyway, point is I'm seeing a lot of these kids. I've had some 17 and 18-year-olds just like that. And I mean, it's no joke. Yeah, and it's sad to see a generation go through that. But I've had, it's not a huge part of my practice. I practice in conjunction with a psychiatrist, but it is one of the most rewarding things to see somebody in that state of mind be able to come out of it and, and they're at one point they're 9 out of 10. Give me the gun. I want to commit suicide. And then after the treatment, you ask them what their number is, and they're like, I'm not sure why I was thinking about that.
So is 2 questions. Is it a one-time treatment? And 2, any idea what the mechanism of action is?
Absolutely. Yeah. Both are known. Most cases, if you're suicidal, no. You need at least 3 to 6 treatments. Lori Calabrese has done a lot. And she was at the Metabolic Health Conference. She's shown the ketogenic diet along with ketamine therapy to help in like suicide and all that. And she's a great person. I enjoyed meeting her. I really enjoyed meeting her at the health conference and recommend looking at her. You definitely need more treatments. One isn't almost never enough. Sometimes it is in like depression, that kind of things, or OCD. And the mechanism is glutamate. So glutamate is the master neurotransmitter. Glutamate's the reason you can ride a bike after 20 years of not riding a bike. Glutamate's the reason your energy levels. There's a guy named Mark Mattson. He was on the IHMC podcast, did a great podcast on glutamate. And that's the master neurotransmitter. And then you have GABA, which is kind of the inhibitory neurotransmitter. And those are your yin and yang of your neurons or your neuroplasticity in a sense. I mean, without going too much in the weeds, ketamine is like fertilizer for the brain. It prepares your brain to be able to change its tracks so that neuroplasticity can take place. And you can, by being able to achieve that neuroplasticity, it's called the default mode network. And basically, It's pretty obvious, people go right back into that line of thinking when they're suicidal, right? Oh my, I want to be happy. No, suicide. I want to be happy. No, suicide. Same thing with depression. So ketamine takes you out of that. And there are ways it does it. And it's all through, it blocks the NMDA. So it's an NMDA antagonist. And this in turn increases glutamate for ironic reasons, actually. And it also increases brain-derived neurotrophic factor, BDNF. So that is something that increases neuroplasticity. And another one is mTOR, the mechanistic target of rapamycin. That's also a protein produced by the brain that's upregulated when these types of drugs. And it just doesn't happen with ketamine. Ketamine's a psychedelic. Like, it also happens with MDMA. It also happens with psilocybin. It can happen with ayahuasca, those kinds of things. It's most studied in ketamine. And what I would say is most special about ketamine is it's the one drug we have now. It's available today, and it's legal through a prescription in a properly medical clinic that everybody can access. That's not true with the other psychedelics and
Right.
technically, right? So that's the power. There might, one day there's going to be things way better than ketamine, I'm sure, just from seeing the research. But it's what we have today. It's what we have that's effective. And I mean, if you're having problems, and you're the mother of a child, why wouldn't you try it? It's not, or at least consider it. And that was the whole point of the book, The Revolutionary Ketamine. And it's not like I've sold millions of copies of it. I've written it, and the people it's affected, it's been a wonderful part of my medical career.
I can imagine.
Yeah.
Wow.
So it's
I would love to just take a deep dive on all of that. Anything that has to do with the brain and the neuroplasticity and the chemicals that squirt around inside there and changing behaviors and attitudes and perceptions. I love all that stuff. And maybe that'll be our second conversation.
Yeah.
And we've had an illustration here in the last hour of what a polymath actually is.
Okay,
This is fascinating.
Thank you.
And you're an anesthesiologist. Wow.
Yeah.
Okay.
Yeah.
Phil, this one's been fun.
Yeah, real interesting thinker as we got to, and just exploring some of these different areas. And, in a lot of ways, I think it exemplifies the journey that many of the physicians in this kind of space have gone through, where they start pulling on that first little, string about something doesn't quite seem right about what I've been told. And it really leads to all these different areas. Yeah, definitely. Thank you, Johnathan. Let people know how they can get in touch with you, read more of your work. If they're interested in working, maybe exploring some of these techniques with you.
Yeah, I'm reachable. I have, my Substack, JohnathanEdwardsMD.substack.com, and it's with an H, Johnathan with an H. I also have, and my website's the same, JohnathanEdwardsMD.com. Again, with an H. I'm on Twitter at John Edwards MD. I'm on Instagram at John Edwards MD. I'm not as good as you with the social media. It's an undertaking. Maybe someday I'll get there, but I just do what I can now. I am reachable. You could go on my website, find my email, reach out to me, and then I can do a Calendly appointment. Those kinds of things. And so it's pretty simple, and I'm happy to talk, and but happy to help. And man, this has been great. Thank you.
Yeah. This is very cool stuff. You're probably going to get some calls.
Oh boy. Yeah, I hope so. I just keep it real, and I'm here, but man, what you guys are doing is great. And I've been in the business long enough. Having this kind of option for health optimization is is great. And I'm starting to pitch a lot of people to Dr. Ovadia as well. So
we appreciate it.
Oh yeah,
absolutely. All right, we will make sure the contact information is in the show notes as always. And I encourage you, listeners. I've been looking at Johnathan Edwards' website and these books. This is just fascinating stuff. The videos that he referenced are also on there. Really cool stuff. And especially for those of you with a loved one who's struggling with suicidal ideation, check it out. Check it out. All right. For Dr. Philip Ovadia and Dr. Johnathan Edwards, this has been the Stay Off My Operating Table podcast. We're grateful you are a part of our audience. Thank you for joining us, and we'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.